So you've now reached week 3 of the pediatric nutrition portion of your course, and we are moving on to module 3. Today we're going into the PICU, or critical care. Our learning objectives are to learn the basics for pediatric critical care in a PICU setting, including understanding and utilizing EN basics, including formula selection and advancement. We're going to introduce PN basics with a brief description and a note of the reference available. We're going to utilize estimated need adjustments for critical care, and then review some common PICU medications, anthropometrics, and expected growth. For most dietitians, the PICU can kind of be a scary place. I know that you've previously had a really great ICU unit, and a lot of that transitions over to the PICU. You'll definitely want to read your Aspen Guidelines for Critical Care, which is required for week 3, along with this presentation. The main nutritional focus in the PICU is assessing patients and providing appropriate nutritional support for the ICU setting. What generally doesn't take place is in-depth education, nutrition-focused physical exams, unless the patient is a chronic one that is admitted for something like a tethered cord release or sometimes a shunt revision, something like that. Then it might be okay to go ahead and do the NFPE. Another thing you want to avoid is long extended interviews. It's a stressful environment, and we want to provide the least disturbance possible as a dietitian. Why do we do this? Because the level of care required, family and caregiver stress, and we certainly don't want to ever be the ones to worsen a patient's condition. Before we dive in too deep, I should mention that this portion of the course will be slightly shorter, as this really is a pediatric specialty. The main thing that I hope that you learn from this is how to approach a PICU patient, perhaps start some enteral nutrition, and the modifications that you need to make for their nutritional needs. So some of the things that take place when formulating and maintaining a nutritional care plan is: when do we see the patients in the ICU? A consult is seen within 24 hours. NPO or clears are seen within 3 days or per hospital screening criteria. And our goal is to have MNT initiation by no later than 48 to 72 hours. This isn't always achieved, but it is our goal. The dietitian attends multidisciplinary rounds every day and answers family nutrition questions. For patient assessment, follow the basic steps you learned in Module 1 for developing a nutrition care plan. When it comes to anthropometrics, you'll have to accept that not all your data is going to be accurate. You should follow it as appropriate, certainly, but understand that your weights may or may not be correct based on how they were taken, patient's fluid status, etc. Your height is very difficult to assess accurately in the ICU setting without disturbing the patients. So do the best that you can and try to obtain additional history on an outpatient basis. That sometimes will help with determining the nutritional status inpatient. Other things that the dietitian may do in the ICU is to check for proper nutrition delivery and administration. Some examples of this is the correct tube feeding running at the ordered rate, and was the patient provided their total daily volume goal. Often they aren't, because tube feeds are stopped, started, held for medications, held for perceived intolerance. So the chances of them getting a full day of tube feeding as ordered sometimes are pretty slim. Another thing to check is the patient receiving ordered supplementation? There are children in there that are taking oral supplementation, and this doesn't only apply to the PICU but also the floor as well. If they are supposed to be receiving oral supplementation, make sure that it's coming. Are the weights checked as ordered? Often this is not the case and you have to put in a weight order if you want to see one. Has the medical status changed, warranting a change in the nutrition care plan? Was the patient extubated, intubated? Did they change the central line to a peripheral line? Did the patient start to eat? Was the diet advanced? All of these things can play a factor in your nutritional care plan as the patient progresses and moves forward or backward. So let's move forward and talk a little bit about enteral nutrition. Not all PICU patients require alternate MNT, but when they do, and if possible, enteral nutrition is the first choice, even if it's just trophic feeds. You can look at the article on enteral feedings for children, which is required reading for week 3, and the charts below and the next 2 slides come from this article. And there's also an article called What's in a Bottle that covers the brave new world of infant formulas. When it comes to formula selection, children that are aged 0 to 1 year old should be given a standard infant formula. From 1 to 2 year old, it gets a little more complicated. Depending on the weight and their diet prior to admit, you could be using an infant versus a toddler versus a pediatric formula. Something to remember is that most infant formulas, unless they're on a special recipe, are 20 cal per ounce, and the standard pediatric formulas, unless they're formula concentrated or reduced cal, are 30 calorie per ounce. So tolerance may be an issue if you've got, say, a 16-month-old who has never transitioned off an infant formula to a pediatric formula, and you change from 20 to 30 cal per ounce. That can cause some problems. So that's something you have to look at. For ages 2 to 12-year-olds, you'll want to use a pediatric formula. And for those children that are greater than 12-year-olds and have an appropriate weight age, you'll want to use the adult formulas. If they have a weight age that is less than 12 years old or other circumstances like developmental delay, often you'll go ahead and go back down to the pediatric formula selections for them. The chart below kind of breaks out the different types of formulas you'll find within each formula group. Most hospitals contract with Abbott, Mead Johnson, and Nestle, so most of the examples I'll provide are from these companies, with your understanding that there are many other formulas also available on the market. I should note that the standard infant formula from Abbott, which is Similac Pro Advance at this point, is a 19 cal per ounce. There are rumors that Similac will go back to the 20 cal per ounce as their base. There was a big uproar about this about 5 years ago when it came out, and we've been hopeful they would return to the 20 cal per ounce as the base calorie level. It makes calculations and figuring so much easier. I should also mention that these formulas do translate to enteral nutrition on the floor, and not only in the PICU. There are, just as in adults, a couple of formulas that are PICU specific, some that just came out on the market from Peptamen for pediatrics that we're really excited about because of the increased protein in them. But most of these formulas do translate to the floor for enteral nutrition. You can see in both categories that there is a polymeric or more standard formula. Then you move to a peptide base, which breaks down the proteins and some of the components more fully. And then, of course, you have a full amino acid based formula that is completely broken down. Soy formulas aren't really used that much, and if they were to be ordered, it would have to be a specialty order, as most facilities don't stock those as a standard. So looking at the infant formula algorithm, you can see the premature classifications up at the top. And like I said, we really wouldn't be getting into the NICU, but these are some of the ones that you would see. Of course, the gold standard is breast milk, and if that isn't possible, we will use donor milk in many cases. There are premature formulas, the Similac Special Care and the Infamil for premature. Those are meant to be used in a hospital setting and are not discharge formulas. Our discharge formulas typically, unless there's tolerance issues for our NICU grads, are Enficare and NeoSure. And both of these are standard 22 cal per ounce formulas. Then you get into your standard infant polymeric formulas, and those are basically the front line for most companies, as in your Gerber Good Start, the Similac Pro Advanced 19 cal per ounce, and the Enfamil NeuroPro. One of the fun things about infant formulas is they like to rename all of them about every 1 to 2 to 3 years, and that really throws a hitch in charts and trying to keep up on the latest names and EMRs. It really kind of makes a mess out of it, but you have to have a marketing idea and follow through on it, that's for sure. If there are specific medical needs or specific intolerances, there are different formulas that you can choose for infants. If you go up to the specialty box, you can see there's Enfaport, that's for chylothorax. You've got Prosobi, Good Start Soy, Portagen, also for chylothorax. RCF is a renal formula. SimM6040 is also a renal formula. Soy Isomil, 19 cal per ounce in your ketogenic and your metabolic formulas, and those are very specialized. For cow's milk allergies or presumed allergies, you have Nutramigen, Progestamil, and Alimentum in Gerber Extensive HA. These all have a protein hydrolysate where they've taken the milk protein and removed the whey and partially broken down the casein. Other components are also broken down as well. My favorite formula in this group is Progestamil because it has a higher proportion of MCT oil and lower osmolality. One of the benefits of Alimentum is that in the ready-to-feed 20 cal per ounce formula, it is also corn-free. We often see corn allergies in our younger children as well. Nutramigen is well absorbed. It's the formula that they would put our cardiac patients on at Primary Children's Hospital and is slightly more broken down than Progestamil and Alimentum. Other formulas that you might see are the ones that remove the lactose. If you go down to the other box on the bottom, you'll see the Enfamil AR, which is a thickener formula with rice added to it. Gentlease Regulin is similar. The Gerber Good Start Soothe, also similar. Then you've got Sim Sensitive, 19 cal per ounce, which is a lactose-free formula, and Similac Total Comfort, which has the casein removed and a whey hydrolysate for the protein component there. We've had pretty good luck with kids tolerating this in the NICU if we don't want to go all the way to a peptide formula. Similac for Spit Up is a thickened formula that is wonderful to use if there's confirmed reflux or we need something that will hold in the stomach for a little bit longer. One thing to remember is that you can't thicken breast milk effectively with any of the thickeners, including the Similac Spit Up or the Enfamil AR, as breast milk has a high proportion of enzymes that begin to break down those thickeners, and you end up with a goopy mess. Doesn't work very well. And finally, you have the amino acid formulas for the infants, which are completely broken down and dairy-free. Elecare for Infants is one of them, along with Neocate Infant and Pure Amino. Elecare also exists for children, as does Neocate, in a 30 cal standard formulation, which is basically Elecare for Infants with a recipe for 30 cal and a few adjustments. So that's kind of the infant formula lowdown, and we're going to move on to pediatrics. For pediatrics, the standard polymeric versions are Boost Kid Essentials. This is primarily an oral supplement that we prescribe for children, something like Boost for adults or Ensure, something along that line. The Complete Pediatric is a blenderized version. There is an adult version as well. Nutrin Junior with fiber, Pediasure with fiber. Those are our standard formulas. If you go up to the specialty, these are ones where you have the soy product that's a drink, also can be used as a tube feeding. We don't see that used very often at all. Then there's a complete pediatric reduced calorie 0.6 per mil, cows per mil that is. It's a wonderful addition to our formulary in that it really helps with our developmentally delayed kids who might have lower needs. Pediasure Sidekicks, one of those oral formulas that kids seem to like. Gotta go with it. Then we move into the peptide formulas, and by far and away the most popular ones there are Peptamen products and the Pediasure peptide versions. You can get them with fiber, with prebio, and without fiber. As I mentioned before, Peptamen did introduce a formula called HP, which increased the protein in it, making it a more appropriate choice for our kids with higher protein needs in the PICU on the vent, similar to what you would see in the Peptamen Intense adult product. So that's something new. Then moving on to the amino acid based formulas, you have Elecare Jr., Neocate, and Vivanex Pediatric. Next, we move into the increased density formulas, which might be appropriate if the child has some fluid issues. You have all of the basic formulas with their 1.5 cal equivalents, Pediasure, the Boost Kit Essentials. Nutrient Jr. does not make a 1.5 cal product, so we will use the Boost Kit Essentials instead of that. The specialty formulas are the Pediasure Peptide 1.5 and the Peptamen Jr. 1.5. If it comes down to it and I have to make a choice, I prefer to use the formulas that are slightly broken down in the ICU setting. I feel like they're better absorbed and better tolerated with some of the medications and perfusion and fluid issues that you might have in the ICU setting. If the child requires a renal formula and they are a little too big for using, say, the RCF or the Similac PM6040, we will look at using NovaSource and possibly dilute it down if we need to improve the tolerance of a 2 cal per mil formula. Now we're going to move on to enteral nutrition delivery. I apologize in advance for the table below. I'm hoping to get a better copy into the slideshow, but this is what we're kind of stuck with at the moment. The routes for enteral delivery are fairly standard: NG, OG, NJ, OJ, G-tube, GJ tube, and several other variations of this. And remember, no bolus feeds into the jejunum, which is very important for children as in adults. Also, most tube feedings are continuous in the ICU setting initially and transition to bolus perhaps when they get to the floor. As I mentioned before, for initiation and advancement, it's generally initiated as a trophic feed, and that's kind of defined as infants from 0 to 12 months, perhaps 1 to 2 mils per hour on up to 5 if it's a big infant. In children 2 to 12, I generally will initiate between 5 and 10, 10 if it's a big kid, 5 generally if it's a smaller child. And for the teen set, you can treat them a little bit more like an adult, maybe initiate at 10 to 20, and then you advance as tolerated. On my infants, I don't ever really advance more than maybe 1 or 2 mils per day, or if they're tolerating really well, I might do an advancement of 1 mil every 4 to 6 hours. Same thing for the pediatrics, except it's in 5 mil increments. I might do an advancement of 5 mils every 4 to 6 hours as tolerated. And then for the bigger kids, you can go ahead and advance between 5 and 10 mils every 4 to 6, or more like you would do an adult. I generally don't tend to advance every 2 hours. There are some practitioners that are a little more aggressive with that, but in the critical care setting, I'd rather see good tolerance and the ability to continue a tube feeding versus having to stop it, restart it, stop it, restart it. That actually ends up affecting the nutritional status a lot more than going more slowly on a tube feeding. You'll of course want to monitor tolerance, and some of the signs and symptoms of intolerance in children are the same as adults: vomiting, abdominal distension and tenderness, bowel loops and gas on x-rays, cyanosis, bradycardia, lethargy, apnea, and respiratory issues. It's not really generally recommended to check residuals, same as in children as in adults, but that's a culture that is hard to get rid of, and most nurses will try to sneak it in just to see what the residual is doing, but we're still trying to get them to do it as a sign and symptom based test. The exception to this rule is in the NICU, where we do regularly check residuals due to the immaturity of these GI tracts. We've got to make sure that they're even moving in the first place. So next, we'll take a look at parenteral nutrition. This is not something that's generally dabbled in without experience in pediatrics on the floor and in the PICU setting. But these are a few tips and tricks, and you can revert to the information you learned in your ICU course, as I know that was extensively covered. So obviously, you know the difference between PPN or TPN with peripheral and central access. TPN also goes by many other names, but for this course, we're just going to call it that. It should be initiated by day 4 to 5 if you're unable to advance your enteral nutrition beyond trophic feeds, or if GI medical condition compromised and you're unable to tolerate EN, say the patient had a bowel resection or they have a post-op ileus and you aren't able to feed into the gut, then get TPN on board, pretty quick, day 4 to 5. You can consider supplemental TPN on day 7 to 8 if the patient has not attained a minimum of 60% of goal feeds and not anticipated to attain this minimum in the next 24 to 48 hours. You can advance appropriately. Generally speaking, most dietitians are involved in the pediatric TPN recommendations and even writing. This can be done by themselves or in conjunction with pharmacy. I've done it both ways. I put a pediatric TPN recommendation resource in your week 3 references, which you can keep and use in the future for TPN reference. General TPN goals for pediatrics is 50 to 60% carbohydrate, 20 to 30% fat, and 20% protein. So not that different than adults per se. And of course, you'll want to monitor labs. That reference also had recommended lab monitoring for pediatrics. One of the things that we're monitoring for in adults and children is cholestasis. This is a potential complication of long and short-term TPN. I've seen kids get cholestasis within 3 to 4 days of starting TPN if their body is really medically compromised. If that's the case and you see a rising total bilirubin, request to have the bilirubin fractionated so that you can see the direct bilirubin. If the direct bilirubin is greater than 2 and or the triglycerides are greater than 200, you need to adjust or hold lipids or consider changing to SMOF or Omegaven if they qualify for this. One thing to watch is for potential essential fatty acid deficiency if you hold the lipids for a long period of time. As far as the specialty lipids of SMOF and Omegaven, which was just recently approved, yay, those you would want to dive in deeper in more of a specialty course. I've used both of them and find that they are a good substitute for interlipids. And I'm sure that we'll see more and more research coming forth as these products have been in the United States and on the market for longer. Omegaven, you do qualify as a pediatric patient if you have a direct bili that's greater than 2 and if you're going to maintain long-term TPN. Another adjustment to make, of course, is to change to cholestasis trace elements. If cholestasis is a problem, adjust the GIR lower, adjust the overall calories down by about 10 to 15%, And then the last thing that you would do would be to decrease the protein in the TPN. So that's just basically a review of how you would look at cholestasis in the pediatric patient. Next, we're going to take a look at adjusting estimated needs for pediatric critical care. If you'll remember back to Module 1, the protein requirements on that sheet that you've got for your cheat sheet also have the variations for critical care and the increased needs there. We're going to discuss calories a little bit more than that at this time. The gold standard for assessing calories would be indirect calorimetry. I love using indirect calorimetry. I've had the opportunity to use it at Primary Children's and Phoenix Children's, and I was always amazed at what the patient showed as far as their estimated needs. Often we were pretty close using the equations below, but there were some times that we were surprised. For instance, there was a patient who, there was some legal issues surrounding this patient, and she was laying on a vent for a very long time. We weren't able to feed her due to some legal problems. It was interesting to watch her estimated needs start at about 800 to 1,000, and by the time that they ended up making the decision for a compassionate extubation, her needs had drifted all the way down to about 400 calories per day. So I find that to be very interesting. For children that are greater than 2 years old, you'll want to shift away from the RDA and WHO standards for well or less acute children to the Schofield equation. And this applies to mainly kids that are on the vent, sedated, and who need slightly less. We don't want to overfeed them or make their time on the vent longer by contributing to increasing CO2 production, etc. So the Schofield equation is the equation that you can use if you have the weight and height and you trust the height, which often I don't, or the WHO is the equation you would use if there's weight only. Don't use activity or stress factors in the first week and possibly longer because you don't want to overfeed the patient. Reevaluate at week 2, and there's a possibility you could increase them slightly. If the patient is less than 2 years old, use 75 to 90% of the baseline needs. The initial goal should be in the lower range of that, once again, to avoid overfeeding, and reevaluate this week 2. What we found is that the Schofield equation doesn't really do a good job predicting in the really low weight patients. So that's why we recommend doing this for the less than 2-year-old patient. As far as protein and fluid needs in the PICU, we talked a little bit about the protein. Those should be increased for critical illness. And once again, you can find those on your cheat sheet. The fluid goals generally remain the same using the Holiday-Seeger method or per MD, understanding that the total volume available for nutrition support will likely be altered by fluids required for medication, blood products, etc. Remember that many of the medications and fluids that they come in do contain dextrose, generally D5, and those need to be figured into the calculations. Free water is generally not given in the PICU setting unless the patient is stable on tube feeds, the MD requests it, or the patient is receiving the tube feed as their primary source of fluid. Now we're going to do kind of a brief blow-by on some common medications you see in the PICU and some of the nutritional implications. Once again, I believe you've covered quite a bit of this in your ICU setting, but there are some that are a little more specific to children, and these are the effects that I've noticed in delivering proper nutrition in the PICU setting. They are similar to adults, like I mentioned. Primarily, you'll see vasoactive medications and pressors, epinephrine, norepinephrine, dopamine, those types of things. Those affect gut perfusion and may contraindicate enteral nutrition in higher doses. Pentobarbital is used for deep sedation and often to treat uncontrollable seizures. This affects gut motility and may also contradict enteral nutrition. A combination of the above indicates a TPN recommendation almost off the bat in children. You can try to initiate trophic feeds to maintain the gut villi, but often you're unable to advance enteral nutrition to goal, and tolerance is a big problem. Also see paralytics frequently in pediatric patients, rocuronium, vecuronium, and or cooling. All of these can possibly affect gut motility as well. Common sedatives for pediatrics patients are Precedex, and in teens you'll sometimes see propofol, but mostly those are bigger teens, adult-sized teens. And then another common sedative is Versed. You see steroids, which, as in other patients, you have the issue of hyperglycemia. And on a respiratory note, the general rule is no PO on greater than 3 liters of high-flow nasal cannula. I had a pediatric intensivist describe it to me as trying to take PO on anything greater than 3 liters of high-flow nasal cannula, stick your head out a car window, and try to gulp down a can of soda pop. He said that's what it feels like to have food on greater than 3 liters of high flow. One thing to note in infants with feedings is often because of the fluid restriction, we will put the tube feeding through to the J on high flow nasal cannula in higher than 3 liter amounts, and we'll concentrate it to 24 cal per ounce minimum so that we can take the fluids down and promote better tolerance. Last, we're going to take a look at anthropometrics and the expected growth in the PICU. First, anthropometrics can be difficult to accurately assess in critical care. This is due to patient care and treatment and our goal to do no harm. Once again, equipment on the bed. Was the bed scale zeroed out? Were you able to use a Hoyer lift, etc.? The inability to accurately attain height and length. That's difficult to do in an ICU setting for a patient who is on the vent. Different calibrations for different beds and standing scales. We've talked about that a little bit before. Fluid retention and resuscitation, and diuresis is more pronounced in the ICU setting and often does give false indicators of weight loss or weight gain. But in general, in acute critical illness, you would not expect usual growth for a child during this acute phase. We want to support them and provide the best nutrition possible, but growth is sometimes not achievable. I would strive to achieve appropriate growth during the recovery phase, which can often last for many months as the child recovers from his ICU stay, depending on what they were there for and the severity of the illness or injury. So that's kind of a wrap on the PICU. I know it was brief and it's just the tip of the iceberg, really, for the PICU and pediatric nutrition in general. This course has covered the basics for assessment, and it's my hope that you are able to take a basic pediatric patient and perform a fairly thorough assessment on them, plus make some recommendations if the patient has to go into the ICU. However, there are many pediatric specialties that require further nutritional adjustments, and hopefully, if there's an interest that you have in pediatrics and you want to pursue this, you can look deeper into it. Once again, please feel free to ask any questions you may have regarding the information. I have seen a wide variety of children in ages, stages, and growth problems, along with adults for that matter. I prefer little people at this point in my career, but I have done adults as well. Thank you for your participation, and good luck in your careers as dietitians.